So I think what we've seen across the board is that, especially with the 5-year data that just came out earlier this conference, is that most patients really, it doesn't matter the subgroup, they're benefiting from the addition of CDK4-6 inhibitors. I mean, we're, I think, for the most part, yet to find a subgroup that doesn't benefit. I know that there's a lot of, there had been initially a lot of concern about whether or not the T2N0 patients, you know, they're only T2N0, maybe it's over-treating them to add a CDK4-6 inhibitor. And, you know, I would say that the data has not borne that out. I mean, they still benefit substantially, and, you know, not just statistically significantly, but clinically, in a clinically meaningful way. And so I think part of the reason why that's really important to remember is that these are not your average T2N0 patients. These are patients who were node negative, but they had to have an additional high-risk feature. So some data presented last year looking at patients in the Flatiron database who sort of met Natalie criteria. The patients who were T2N0 had approximately the same risk of 7-year distant relapse as patients who were node positive. So I think that it's not just the anatomic staging that's important to remember when thinking about which patients we should select or benefit, or maybe not benefit from. It's really about the additional biological risk that was studied in the Natalie trial. Beyond that, I don't think that response to neoadjuvant therapy should help guide that decision. I think that if someone, you know, if someone had high enough risk disease where it was felt that they should get, you know, neoadjuvant chemotherapy, which most patients on Natalie, if they got neoadjuvant chemotherapy, they were the highest risk population. Certainly, it would be warranted to kind of throw the kitchen sink. That's exactly the group that you would want to give them additional CDK4-6 inhibitor.